Endocrine Surgery, written and narrated by Dr.Boyd. Lingual thyroid is an abnormal mass of ectopic thyroid tissue seen at the base of the tongue caused by failure of normal caudal migration of the thyroid from the foramen cecum. The incidence is 1 per 100,000 to 1 per 300,000 people. Female predominance of occurrence is seen 7 times higher than that in males. For 70%, it's the only thyroid tissue. Clinically, lingual thyroid may manifest with symptoms such as dysphagia, dysphonia, or even bleeding and upper respiratory tract obstruction. Technetium scintigraphy is the most important diagnostic technique employed in the identification of this ectopic thyroid tissue. Treatment options include thyroxine, which suppresses TSH stimulation and minimizes goitrous enlargement. Monopolar coagulation and laser CO2 are the most widely employed techniques for the smaller lesions. Ablative radioactidine therapy is an alternative approach recommended in older patients or patients who are unfit for surgery. If there is no thyroid tissue in the neck, surgical excision with autotransplantation is the treatment of choice. Thyroglossal duct cysts are the most common congenital cervical anomaly. They can form anywhere along the thyroid's route of migration between the tongue and the inferior neck. They often present as a midline neck cyst closely associated with the hyoid bone. The mass will elevate with tongue protrusion or swallowing. The mass is most commonly found at or below the level of the hyoid. The treatment of thyroglossal duct cyst is surgical removal to include the cyst, the tract, and the mid-portion of the hyoid bone, a cyst-trunk procedure. Hashimoto's disease, or Hashimoto's thyroiditis, also known as chronic lymphocytic thyroiditis, is an autoimmune disease that leads to the destruction of thyroid follicular cells. This autoimmune condition is most common cause of hypothyroidism in developed countries and is characterized by the formation of anti-thyroid antibodies which result in progressive fibrosis of the thyroid. The female-to-male ratio is at least 10 to 1. The incidence of Hashimoto's thyroiditis increases with age, and the most cases are found between the ages of 45 and 55 years of age. A majority of individuals with Hashimoto's thyroiditis are euthyroid with normal thyroid function tests. About 20 to 30% of individuals with Hashimoto's thyroiditis develop hypothyroidism. As lymphocytic infiltration progresses, patients may exhibit signs of hypothyroidism, including a large goiter, weight gain, cold intolerance, fatigue, and myxedema. Enlargement of the thyroid is due to lymphocytic infiltration and fibrosis. The mainstay of treatment for hypothyroidism that develops due to Hashimoto's thyroiditis is thyroid hormone replacement, not thyroidectomy. Graves' disease is the most common cause of hyperthyroidism, accounting for 60 to 80% of cases. The overall prevalence of hyperthyroidism in the United States is 1.2%. In hyperthyroidism, the thyroid gland produces excessive amounts of thyroid hormones. Signs and symptoms vary between people and may include irritability, muscle weakness, sleeping problems, a fast heartbeat, tachycardia, diarrhea, enlargement of the thyroid, hand tremor, and weight loss. Graves' orbitopathy, or thyroid eye disease, is caused by inflammation, cellular proliferation, and increased growth of extraocular muscles and retroorbital connective and adipose tissue due to the actions of thyroid-stimulating antibodies. Treatment consists of rapid symptom control and reduction of thyroid hormone secretion. Options include antithyroid drugs, which block thyroid hormone synthesis, radioactive iodine treatment of the thyroid gland, and total or subtotal thyroidectomy. Thyroidectomy is preferred for patients with very large goiter and/or anterior neck compressive symptoms. Parathyroid disease. The parathyroid glands function to secrete parathyroid hormone, PTH, to maintain intravascular calcium hemostasis. The active fragment half-life is about 3 minutes, which results in rapid control of serum calcium. Hypocalcemia stimulates PTH secretion, and hypercalcemia inhibits PTH secretion. PTH increases serum calcium via 3 distinct mechanisms: an increased calcium resorption by the kidney, stimulation of osteoclasts to release calcium from the bone, and increased gastrointestinal absorption of calcium. Hyperparathyroidism is usually found by routine testing showing an elevated calcium. The diagnosis is confirmed by an increased level of intact PTH. Although once known for the aphorism as a disease of stones, bones, groans, and psychic moans, primary hyperparathyroidism is usually asymptomatic when initially diagnosed. Symptomatic parathyroid disease will most commonly manifest as symptoms of hypercalcemia, such as bone pain, fatigue, polyuria, nephrolithiasis, and neuropsychiatric disturbance. Primary hyperparathyroidism is most common identifiable cause of hypercalcemia diagnosed in postmenopausal women. The incidence in females is approximately 3 to 4 times that of men, and the peak age group is between 50 and 60 years of age. Neck ultrasonography and parathyroid nuclear medicine sestamibi scans are standard imaging tests for the localization of hyperfunctioning parathyroid glands. The parathyroid glands are small, oval-shaped structures found close to the thyroid. The average parathyroid gland is approximately 6 millimeters by 4 millimeters, weighing only 20 to 40 milligrams. 85% of patients have 4 glands posterior to the thyroid, with 2 lying superior and 2 lying inferior. A single parathyroid adenoma is responsible for 80 to 85% of primary hyperparathyroidism, with double adenomas the culprit in about 4 to 5%. 4-gland parathyroid hyperplasia is present in 10 to 12% of patients. Parathyroid carcinomas are very rare causes of hyperparathyroidism and account for less than 1% of the disease. A parathyroid sestamibi scan is the preferred method for identifying abnormal parathyroid glands. Because a single adenoma causes 85% of the disease, minimally invasive parathyroidectomy is emerged as the standard for parathyroid adenoma treatment. Intraoperative localization of parathyroid tissue is accomplished with preoperative injection of the sestamibi nucleotide and the use of an intraoperatively handheld gamma probe. Due to the short half-life of PTH, the Miami criteria dictates that the PTH level should decrease by 50% within 10 minutes of adenoma removal. Adrenal gland disease. An adrenal incidentaloma is a mass lesion greater than 1 centimeter in diameter, serendipitously discovered by radiologic examination. It's found in about 4% of high-resolution CT scans. 80% of these are non-functioning. 5% are pheochromocytomas, and less than 5% are adrenal cortical carcinoma. One must determine if the lesion is functional or not. To evaluate for cortical excess, an overnight dexamethasone suppression test is done. Plasma-free metanephrines are evaluated to look for pheochromocytoma. CT scans aid in answering the question of whether the lesion is benign or malignant. A malignant lesion is radiodense, homogeneous, has late washout, while benign tumors are less dense, heterogeneous, and exhibit early washout. Those tumors less than 4 centimeters and non-functional are followed with imaging at 6 to 12-month intervals. For lesions that are greater than 4 centimeters or indeterminate or with malignant features, resection is indicated. All functional lesions are excised. Conn syndrome, or primary hyperaldosteronism, is excessive production of aldosterone by the adrenal due to adenoma 60% of the time and hyperplasia accounting for the remainder. Symptoms include hypertension, hypokalemia with muscle weakness and cramps. Workup will reveal hypernatremia and metabolic alkalosis with decreased renin levels and an elevated aldosterone-renin ratio. There is an expanded extracellular fluid volume. Adrenal CT will confirm and localize the adenoma if present. Treatment is unilateral adrenalectomy for those with unilateral adenoma, and for those with hyperplasia, aldosterone antagonists such as spironolactone or other potassium-sparing diuretics. Pheochromocytoma is a rare tumor originating in the chromaffin cells in the adrenal medulla. Pheochromocytomas clinically manifest as overproduction of catecholamines. Clinical manifestations arise mainly from catecholamine excess, and about half of these tumors primarily produce epinephrine, while others mainly excrete norepinephrine. Diagnosis is confirmed through a biochemical testing measuring the excess production of plasma-free metanephrin and catecholamines, and imaging studies to identify the lesion. Pheochromocytoma is a neoplasm that can be either benign or malignant, and is often associated with familial syndromes such as neurofibromatosis type 1, multiple endocrine neoplasia type 2, and von Hippel-Lindau disease. The rule of 10 states that 10% are bilateral, 10% are malignant, and 10% are extraadrenal. The treatment for pheochromocytoma is preoperative alpha and beta blockade, which is essential. Unilateral adrenalectomy can be accomplished utilizing minimally invasive techniques. However, large tumors will usually require open technique. For bilateral tumors, bilateral partial cortical-sparing adrenalectomy is required. Multiple endocrine neoplasia, or MEN syndromes. Multiple endocrine neoplasia type 1, or MEN1, also known as Wermer syndrome, is the development of neoplastic lesions in the pituitary, parathyroid gland, and pancreas. Hyperparathyroidism is present in more than 90% of patients. Four-gland hyperplasia is usually seen with asymptomatic hypercalcemia as the most common manifestation. Multicentric pancreatic islet cell tumors occur in about 60% of patients and are the main cause of death. Gastrin is secreted by many non-B cell tumors, gastrinoma. Increased gastrin secretion increases gastric acid, and increased gastrin secretion leads to peptic ulcers in more than 50% of those with MEN1 syndrome. Usually the ulcers are multiple and atypical in location and often bleed and/or perforate. Among patients presenting with Zollinger-Ellison syndrome, 20 to 60% have MEN1. Pituitary tumors occur in 15 to 40% of MEN1 patients. About 25% of pituitary tumors secrete growth hormone and prolactin. Excess prolactin may cause galactorrhea, and excess growth hormone causes acromegaly. Multiple endocrine neoplasia type 2, or MEN2, also known as Sippel syndrome, is the development of neoplastic lesions in the adrenal gland, the parathyroid gland, and the thyroid. Cases are usually diagnosed after the third decade of life. There's a 100% penetrance of medullary thyroid cancer in MEN2, with pheochromocytoma in about 20 to 50% of cases, and primary hyperparathyroidism in 5 to 20% of cases. MEN2B is pheochromocytoma and medullary thyroid carcinoma associated with marfanoid habitus and mucosal neuromas. This slide summarizes the findings in the MEN syndromes. Nodules in the thyroid gland are a common entity and are detected in approximately 5 to 7% of the adult population just by physical exam alone. Thyroid nodules may be solitary, multiple, cystic, or solid. More than 90% of detected nodules are clinically insignificant benign lesions. Thyroid nodules are approximately 4 times more common in women than in men. Thyroid nodules are clinically important as they may represent thyroid cancer in approximately 4 to 6.5% of cases. Most thyroid nodules are asymptomatic, and most individuals with thyroid nodules are euthyroid. Initial evaluation of patients with thyroid nodule should include history, physical exam, measurement of TSH, and thyroid ultrasound to characterize the nodule. Thyroid uptake and scan can demonstrate if the nodule is functioning, a hot nodule, or not functioning, a cold nodule. Approximately 30% of cold nodules are malignant. Diagnostic workup includes serum markers, cytology by fine needle aspiration, and potentially several imaging modalities, but most commonly ultrasonography. Benign thyroid nodules may be treated with radiofrequency or cryoablation. The 4 types of thyroid cancer include papillary, follicular, medullary, and anaplastic. Papillary thyroid cancer is the most common thyroid cancer, accounting for 70% of all thyroid cancers. It spreads directly by lymphatics. Ultrasound may show microcalcifications. The treatment of choice is total thyroidectomy. Postoperatively, adjuvant radioiodine therapy is given, and lifelong thyroid hormone replacement is indicated. The overall 5-year survival is 95%. Follicular thyroid cancer accounts for approximately 15% of thyroid cancers. It spreads by the hematogenous route. Follicular cancer occurs in the elderly population and exhibits high levels of thyroid-binding globulin, or TBG. The treatment is total thyroidectomy. Radioactive iodine therapy after thyroidectomy is used for remnant ablation of normal residual thyroid tissue, as an adjuvant therapy for subclinical micrometastases, or as treatment of apparent local or distant metastasis. Medullary thyroid cancer originates in the C cells of the thyroid, and serum calcitonin is a reliable marker. But 20% of the time, it's a part of MEN2 syndrome. Diagnostic workup includes serum calcitonin and CEA levels. RET gene mutation testing is mandatory. The patient should be screened for pheochromocytoma. Ultrasound and fine needle aspiration makes the tissue diagnosis. Overall, after total thyroidectomy and central node dissection, the survival rate is 90%. Undifferentiated or anaplastic thyroid cancer is a rare tumor accounting for less than 1% of all thyroid cancers, but it's definitely the most aggressive, and it accounts for 50% of all thyroid cancer deaths. It occurs in females twice as often as it does in males and can occur in a long-standing goiter and then become a dedifferentiated thyroid cancer with rapid onset and progressively enlarging neck mass. The patient will present with dysphagia, stridor, symptoms of tracheal compression. The mass is hard and irregular. Diagnosis includes CT and fine needle aspiration. Surgery is rarely helpful. Radiation can be palliative, and chemotherapy has minimal effect. Often tracheostomy is required. The median survival for undifferentiated or anaplastic thyroid cancer is 3 to 6 months, with 1 year being less than 20%.